Yeah, we're broadcasting.
Okay, good. Okay, welcome everyone. My name is Beth Boudreau. I'm responsible for professional education at Navident. Welcome to our program. We're excited to have you here. Our topic is digital dynamic sinus and dynamic shield. Our speaker is Dr. Isaac Tawil, and our moderator tonight is Dr. Scott Ganz. We like to keep these programs very interactive, so I would encourage you to type in your questions, and Dr. Ganz will be keeping an eye on everything you need to know, have to ask, and he will be fielding those questions. At the end of the program, we do have some time built in for Q&A, and also at that time, I will give you the instructions for your to acquire your CE credit. So Dr. Ganz has been published in over 120 peer-reviewed scientific journals. He's contributed to chapters in at least 15 textbooks. He delivers presentations both nationally and internationally and is a featured speaker on prosthetics and surgical phases of implant dentistry. Scott is acknowledged as one of the leading experts in the field of computer utilization for diagnostic and interactive treatment planning, the applications of CBCT and CAD/CAM in dentistry. Dr. Ganz currently serves as editor-in-chief of CAD/CAM and Cone Beam, international magazine of Cone Beam Dentistry. He is on the editorial staff of peer-reviewed International Journal of Implantologie. And Dr. Ganz is the past president of the New Jersey section of the American College of Prosthodontists and the past president of the CAI Academy. Dr. Ganz, the screen is all yours.
Thank you, Beth. Wonderful to be here from 35,000 feet. While we're all quarantined during this crazy time, it's very nice that we have people chiming in literally from all over the world for this presentation. And it's really an honor to be able to participate as a moderator with my dear friend and co-director of our Advanced Implant Education, AIE, live surgery programs, Dr. Isaac Tawil. It's just been a wonderful experience getting to know Isaac over these many years and having the opportunity to be able to spend so much time together at various programs around the world, and our relationship with many of the different technologies that he's going to share during this presentation, and many of the organizations that we also belong to. Dr. Tawil graduated from the New York College of Dentistry, and he is a knight of the organization associated with Megagen, which is Minec, and also, of course, co-director of the Advanced Implant Education. He also is now a co-owner of TBS Instruments, TBS Dental, and works very closely with Megagen on many of their new component design, as well as a consultant and KOL lecturer. It's also nice to be able to work with Isaac with the Digital Dentistry Society, which is a global organization to pursue excellence in digital dentistry. And of course, one of the other issues that's facing us today with this global pandemic is, as we are dentists, we have to deal with all sorts of different issues that are going to face us today with emergencies, but also in the future when we get to open our practices up. And Isaac is very involved with the new concept called slow dentistry, initiated by our good friend Miguel Stanley. And this is really very timely for what we're going through today. Isaac has been on the main podium of many different organizations, including the AAID, the AMIB, Tsunami, SciFac, the Megagen International Symposium. He works very, very closely with the concepts of Densification, was on the main stage at their recent symposium, Dental XP and the IADI. And we've had the opportunity to publish together. He's also published several other articles, which you'll see during the presentation. And he really is one of the finest clinicians that I have seen in all my years in the industry, as well as an incredible educator, and which is why it's been just such an honor and a pleasure for me to be associated with him with our live surgical programs and many of the workshops that we give around the globe. So without taking all of the rest of the time, I'd like to introduce my great friend and colleague and co-director. He's going to be talking about digital dynamic solutions. This is really one of the most amazing uses of technology. And of course, I cannot leave out the association with Navident and the dynamic guided surgery, which we're going to be talking about during this short lecture. Thank you very much, Isaac.
Thank you, Scott.
Right from the Starship Enterprise.
Yep, all on board as we go. It's an honor for me to be introduced by you, by my mentor. It's truly a privilege that you're introducing me, as I could think of nobody else who would be better suited for this, as this is a new evolution of digital dentistry. And from the original digital dentist, we can't thank you enough for your contribution. So it really helps us get a great kickstart to what we're going to be doing. And feel free to chime in during this lecture at any point in time. As you know, you are my dearest friend, and without you, I don't think I could do any of the work that I'm going to show, and which is why a lot of this work that we're going to show is going to have your name on it. So moving forward, this digital dynamic solutions, talking about two different concepts that we're going to specify about. One of them is going to be the digital dynamic shield, which is through the concept of partial extraction therapy. You may have heard of the word socket shield or root membrane. The other is going to be crestal sinus augmentation. OSSEODENSIFICATIon has been a tremendous adjunct to our treatment planning and to our cases in our offices, and having the ability to be able to access from a crestal approach in the same manner as a lateral approach and get the same type of lift has truly been remarkable. And so we're going to discuss some of the various ways as to how we can go ahead and make that digital. So we have to pay homage to where it is due. And without the works of Henry Salama early in the 1990s, partial extraction therapy would not exist. And in the early 90s, you see this case that's showing up on the right side of your screen. You see this little root tip here that's been retained. And it was left intentionally to be retained to try to have some ability to hold over the buccal plate of bone and the soft tissue, more importantly, the soft tissue that goes along with it. Because when we're dealing in the cosmetic space, the worst thing we can do is actually do damage or trauma to the area, because it's going to remove that periodontal ligament. It's going to create a lot of trauma, and we're going to get resorption, and we'll lose part of that buccal plate. So this concept of submerging the roots for aesthetic purposes underneath bridge work was really a groundbreaking work, and it was published by his brother Maurice and through Henry and others in 2007. But again, the case was done in the early 90s, which is remarkable that we were thinking about this that long ago. Some of the contributions that Dr. Scott Ganz had mentioned, and some of the papers that we're on, one of them that he's on that's not on here at the moment, but are these root membrane technique. Working very closely with the Greek group, with Dr. Mithiadis Mithias in Athens, Greece, and his group, and his mentor, Dr. Simon Press, who was the original dentist to work on humans and using this technique, and they call it the root membrane technique. They now are almost up to 15 years. It'll be next year, will be a 15-year anniversary. I can't believe that I'm actually saying 15 years of doing this type of technique, this partial extraction therapy, which they call the root membrane technique. So it's truly revolutionary technique that was not something that's very, very new. It's been around, needed to be validated. And now that it is validated, we've been publishing more and more papers, as you notice in the right-hand side of the screen. Both myself and Mitzias and Scott were publishing in Dentistry Today, and there are other articles on the horizon very shortly. And there was some histology that was done as well. There was some animal histology that was done by Hertzler and Baumer and others, and that's great. And I love animal histology. The problem is that most of my patients nowadays are humans. So it's more beneficial for me to be able to get some human histology, and not to take anything away from the great works of Marcus Hertzler and Zur and from Baumer. It was phenomenal, and we needed that step to be able to go into this human trials of this. And being able to now have human histology, both from my dear friend, Chuck Schwimmer. He did a wonderful histology section, as you see on the left-hand side of the screen over here, and from my dear friend, Dr. Miltiadis Mitzias, and his root membrane concept. Both these cases were from a failed case. So it's not so easily obtainable because we actually have to have a failure. And it's quite difficult when you're having a lot of success to try to find some failures and then be able to capture those. So it's great that we actually have a couple of cases. It's great that we have some human histology to validate this. And it's not a partial extraction therapy lecture per se, so I don't want to get too detailed into the concept of what partial extraction therapy is, except for the fact to say that we're retaining part of that buccal plate of the room, and we are going to have a remaining shield, so to speak, or membrane of tooth that's going to remain to help keep that PDL, to help keep this periodontal ligament intact. When we have it intact, then we're going to stop the resorption of the buccal plate, and hopefully we're stopping the resorption of the keratinized soft tissue. And there are more studies going into that as well. So having different names, whether you call it root membrane, partial extraction therapy, socket shield, doesn't really make a difference. The concept is all the same. We're retaining a partial root fragment. And the name partial extraction therapy and then breaking it down into different techniques and so on and so forth can be elaborated further in another lecture, but this is really mostly about this concept itself. We also have to thank the team from the partial extraction therapy group, notably Dr. Gluckman, Salama, and Dr. Jonathan Dutois, who did some wonderful works and doing some early work, step-by-step work to show what the technique should be in an orderly fashion, to give you a playbook, a step-by-step playbook as to how you can go ahead and perform these techniques. And there's another concept coming out as well with the root membrane article as well. And there are more and more articles. Every month we're seeing more and more articles being published about this. So it's not a new concept, but there are a lot of different names. So if we could just move past the name part and just move into the actual benefit of the technique, which is a periodontal ligament mediated approach to retaining that buccal plate and soft tissue. So this is the partial extraction therapy research group started by Dr. Howard Gluckman and moderated by Dr. Maurice Salama. And you can see some of the amazing speakers that are on this list here. You have some wonderful people like Jonathan and Sinjana and Marcelo. We'll talk about Joey a little bit later. And then Darcio and Salahu Ways, who is the inventor of OSSEODENSIFICATION, and Udata from India, who published a textbook recently, and Hakan and Richard Martin from Texas, and Jorge Campos, who has recently decided to retire out of Spain, and Armando Panzi and Chuck Schwimmer from Pittsburgh, Ehab Musa, a young, extremely talented clinician out of Louisiana, and Ali as well, who published a textbook with Udata, and one of my favorites, Natalia Bodraghi, who is also giving a partial extraction therapy lecture webinar this week, which I highly recommend. You will see some of the most beautiful photos you will ever see in his webinar. So please check out his webinar. You can probably find it on Facebook quite easily. But the benefits of partial extraction therapy do not just remain in the anterior segment. This is not just a pretty face type of a picture. This is something that we are having issues with. So we may have a lot of keratinized tissue in some areas and not in others. And in this picture over here, you'll notice that we lost a lot of keratinized tissue with this implant. Maybe the implant should have been placed a little bit more lingually. I can't argue that. However, we have a nice amount of soft tissue, and then all of a sudden we end up with this food trap, or I like to call it a dessert tray, that ends up remaining in the posterior section because we often lose a lot of that buccal plate. So it's not just for the anterior segment. We can perform this partial extraction therapy technique in the posterior region as well. So it's not something that's just remaining just for the anterior segment. We can treat this posterior tooth just like as if it was two separate teeth, as if we had a mesial and a distal tooth, and we can keep these remaining fragments here and be able to retain this soft tissue here. And when we do that, we can place the implant simultaneously. And when we place the implant in, we're now starting to already start to work on emergence profile with our implant. We're going to get a nice ISQ reading, but the day that we're extracting that tooth, we're already working on emergence profile. And when we put in these healing abutments, we already start to develop that, keep that soft tissue or retain that soft tissue. And as you can see in this slide here, I mean, this looks to me like it's almost like a remaining root tip. So if we blow that up and we examine the entire area, we can see just what that appears to be like. We can see these little pieces of root that can be embedded all the way underneath. And we want to reduce this enough about to the level of the bone, but look at the amount of soft tissue that we're retaining. So we're not going to end up having one of these collapsed buccal ridges, and we're not going to have one of these food traps. So then we enter into the world of 3D dentistry, and we start to intraorally scan our patient, and we can go ahead and deliver them a final crown just a few weeks later. And when we look at this from a occlusal point of view, or a CBCT, we're going to see that we've retained that buccal plate. We've kept it intact. And we look at it from the coronal or occlusal point of view. Here was a case where we did an immediate extraction and lost that soft tissue. Yet with the partial extraction therapy, we've retained all that soft tissue. We've retained that vestibule. And if we had to think long-term, what's going to happen here, we can be fairly comfortable with what is going on here by this molar. But we don't know what the longevity is going to be in this case. And it may need some future work down the road. So this is not just a cosmetic solution. This is a functional solution. The other concept that we're going to be describing is crestal sinus augmentation. I very much like doing lateral lifts. I've done them for years. But now, since the advent of osteodensification, my amount of lateral sinus augmentations has been reduced dramatically. Where years ago, I might have been doing about 6 or 7 lateral sinuses a month. Now, I might only do 5 or 6 lateral sinus in a full year because of this technique, this technology that has evolved through osteodensification. And osteodensification is basically a reverse drilling concept. And if we can take that concept, which we have, and we flip it upside down, we can help to try to elevate the Schneiderian membrane in a crestal fashion instead of going in that lateral modality. The other thing that I've been using a lot in these types of cases, and I'm describing this to you here because I think it's important for us to understand that we want to try to lift the membrane as much as we can. So the burrs can do it quite well, and using a tool such as this NovaBone syringe material can help us access that sinus membrane and help to continue the sinus lifting without having to do much effort. Kind of finishes it off, that hydraulic lift that we were getting from the hydrodynamic lift that we were getting from the osteodensification drills. So when we look at this pre-op CBCT, and you can see what the sinus looked like, we have a nice healthy membrane here. It's not pathological and it's not too thin. This is a great case to be able to lift this section here to try to elevate the Schneiderian membrane. And we do that using the series of these osteodensification drills called Densiburs. And we fill that in with the NovaBone in between. And we go back and forth and just keep adding more, back and forth, back and forth. Sometimes we'll never see the Schneiderian membrane. Other times we will see the membrane because there's not a lot of residual bone height. And this NovaBone will actually really help you create almost like a buffer and push the membrane for you. So it's doing a little bit of the work that you need to be able to do that. Then here we are placing our implant simultaneously, and this can be done in a two-stage approach. However, I very much like trying to get an implant in. If I can minimize the amount of surgeries, I like to get the implant in, and then the implant also gives us the ability to tent the sinus membrane at the same time. So we don't have to rely on putting too much bone.
So Isaac, what would be the minimum amount of height of bone in that for a transcrestal that you would think would allow you to stabilize the implant?
So I think early on, it's a question of experience. And I think early on, the residual bone height should be somewhere in the neighborhood of 6 to 7 millimeters, and practice tenting up that bone about 2, 3, 4 millimeters, trying to place, let's say, a 10 millimeter implant in. But as you know, as I showed you a case just the other day, where we only had 3 millimeters of residual bone height, and I placed a 13 millimeter implant and lifted the sinus to a 15 millimeter capacity. So we can do a lot, but the question is how much should we do and what's responsible for the patient? And I think it's an experience factor, just like anything else. You know, when we're first placing implants, do we do immediate implants? Do we immediately load the same time? Or do we do maybe a socket preservation, come back, place our implants, and go along from there? So I would say you need some sort of a amount of retention for the implant itself. So let's say 2 to 3 millimeters would be the minimum that I would attempt personally, and by placing an implant simultaneously. But if I did not want to place an implant simultaneously, I could come back and do the lift first and come back and place the implant at a later date. Certainly nothing wrong with that. So,
and you took an ISQ measurement, and how important is that, you think, for the understanding of what's happened to the integration process over time?
So as I've learned from you many years ago, and I continue to learn now, and we'll show in some slides in a little bit, that I can't operate without that ISQ. I do not know how I ever did, and I would not want to work in a world where I don't have a scientific measurement or an objective measurement for me to be able to determine when that implant is stable. And so having that, and then being able to re-enter and not doing something invasive, not having a subjective tool, but an objective tool to measure, I can check from day one now, see what my measurement is like, go in, just showing a quick post-op, you can see how much sinus membrane we've lifted. I mean, it's a tremendous amount of bone that we filled into this site. But then we can come back a little bit later, and if we have good ISQ readings, we could load this just a few short months after, so 3 months after, whereas if I was doing a lateral lift in this case, I might not revisit this for 6 months. But since I have an ISQ and an implant in the same day, I can install my scan abutment. If I have a proper reading, which I did, in this case above 70s, intraorally scan my patient, and then deliver a final crown in just about 3.5 months after doing this lateral crestal sinus approach. So I think this is quite important that that we develop this tissue, and you see the post-op here on the X-ray, and you're starting to see some bone integration of that nova bone in the 2D X-ray, but of course 3D tells it all, and you can see the 3D X-ray starting to build up a height of bone. This is 18 months after post-op scan. So we're seeing what we can get, and we can see the longevity, and we can see the quality of the bone in the CBCT here, and we're getting an excellent result. So the term osseodensification, I think, is quite important to understand. This is a dynamic non-subtractive bone instrumentation method, meaning we are not extraction drilling. We are drilling in reverse to use auto-compaction. So it's important to note that with auto-compaction, we need to have good viable bone. We do not want to be placing bone that and then coming back and using that bone that may be a xenograft or a hydroxyapatite bone, because we may end up with necrosis of that bone because it's not a vital bone substance. So when using osseodensification, whether it's sinus lifting or not, please stay away from things like bovine bone because we are preserving the mineral content, and there is no mineral content that's been turned over with xenograft or with hydroxyapatite type of bone. And I see Ziv Mazor just chimed in. I think he's as much of an expert on this technique as you can find. And note to please check out some of his webinars. Thank you, Ziv, for joining us. So this multi-center retrospective 5-year follow-up was done. I was very proud to be a part of this. There's also a wonderful 5-year post-op on the sinus aspect of that, published by Dr. Ziv Mazor and from Salah Haways, which I highly recommend you following up. And I'm proud to be a part of this osseodensification team, proud to be one of the faculty members at the Osseodensification Academy, which is opening up just a few short months. Hopefully, with the way things are going, we'll be able to open and move along quite soon. So now the key is to create the digital handshake, something that I learned from Scott Ganz many years ago. Being able to take all this information that we have and convert it into the digital world. So we can get a lot of information, but how are we going to use that information? So this is why I like to call it the digital handshake, bringing analog and digital together. And this philosophy, which we just mentioned about a moment ago, which right, this is a slide from my mentor, Dr. Ganz here. And there are two technologies that him and I just will not work without. After listening to many years on the ICOI podium, it finally rang through my head about 8 years ago that I must have a CBCT for diagnosis, and I need to have radiofrequency analysis or implant stability quotient, be able to tell much more about this healing of the implant, the stability of this implant placement. And we employ all of these technologies that you've seen here in our facilities in Tijuana, in Arizona, in Florida, where we can come and practice live surgery. But in AIE Dental, we've brought these concepts to become paramount into everything that we're going to do for all of our cases. We must have these techniques available to us for us to be able to implement them case by case, patient by patient, because we don't know what we don't know until we can go inside and take a look. And the least invasive way for us to go and take a look is through cone beam technology. And the least invasive way for us to be able to tell when an implant is ready is through that ISQ. And it's not through torque. Why don't we rely on torque? Why isn't torque our standard of measurement? And part of the reason is that it does not measure lateral stability. It's a second stage test that could become quite invasive. For those of you who have reverse torqued your implants to see if they're ready, when we reverse torque and we pull an implant out, the game is over. Or maybe you push it back in and you say a little prayer and you hopefully pray that maybe that will integrate. So it's a very invasive way. So torque is not the measurement of choice for us to be able to monitor. We, as Michael Norton said in 2013, that torque is a static measurement of placement, and we need to monitor the process of osseointegration, which is a dynamic process. This is not a static process. It's constantly changing. So we need to monitor it in a non-invasive way. And I asked Scott Ganz for another interpretation of that because I think he once said it and it rang true a little bit even more, is that torque is the frictional resistance of that implant as it enters the osteotomy at that moment in time. And then when you hear him lecture all the time, he goes, and only at that moment in time. Why only in that moment in time? Because when we go in and we do a case, it could be a full mouth case. It may take us hours to finish that case. Maybe doing a restorative full arch case. And it may be the posterior maxilla, and it may be very soft cancellous bone. Maybe you've done some bone reduction and removed a lot of the cortical lining. So now we think we have good stability. We put in an implant at 35 newtons worth of torque. Then in 2 hours later, when we're finally able to load that implant, we go into torquing the abutment at let's say 35 newtons, or load the implant at 15 newtons, and the implant spins. And I see this quite often. We see this in our live surgery programs as well. So we cannot use that as our guiding tool. It's a constantly changing process, osseointegration. And we need to have a tool that can measure it objectively and non-invasively, and that is the RFA devices. The RFA devices are the objective measurement of this. So the question that Dr. Ganz always says is, do you ISQ? And the answer from me is always going to be, yes, I do. And there's all types of new devices that have come out. This is the brand new Meg ISQ Ostel Beacon. It's a very nice compact unit to that, and really like the science behind that. Over 1,000 papers in the literature are quoting this device, or this Ostel device, and that's great to have that behind you as a medical legal entry into our documents. I don't think there's any other way that we can do this objectively and medical legally. As far as looking at 2D and 3D, we see this picture of Prince William here. This is when he just had his baby. And we see on the left-hand side, and it looks like he's giving a not so friendly signal to the crowd. But when we look at this from another angle, we actually say, he's actually saying that now he has 3 to take care of. He has him, his wife, and his newfound baby boy or girl, I forget which one, but that their new baby that they now have to take care of. So this is a perception versus reality. When I show you this Rubik's Cube, and a lot of you are thinking, well, how am I going to get these 4 blue dots to match with these 2 dots and that 2 dots? And then if I show you this and say, well, guess what? It's actually not a Rubik's Cube. Or if I show you this piece of tape and you're wondering how you're going to cut the pieces off. Or if I show you this sneaker and you're thinking about like those laces and the design. So this is a perception versus reality. And so we need to have something that's going to give us a more 3D perspective of what we're doing so that we don't have this problem of perception versus reality. And the AAMOR has felt that this should be the standard of care and is the standard of care. And we are doing more and more work with this, with these cone beam devices so that we can have these 3D technologies. We can do digital smile designs. We can do facial scanning. And once we have all the information, then we can, at our fingertips, then we can go ahead and assess the values. I always like to quote this article that Dr. Ganz published about 200 years ago when cone beam first came out, called Improved CBCT Diagnosis Acute with the lift lip technique. One of the most valuable tools you will ever use once you have a cone beam, being able to just put a little bit of a cotton roll underneath the lip there. And yes, this does look like an elephant, but once you have that, you can assess that buccal plate. You can look at that soft tissue. It gives you another picture. So not having the tools is great, but knowing how to use those tools is even better. So I encourage you to read that article. You'll learn a lot about what we can see and what we can assess, and a little bit about the triangular bone concept as well that he's discussed many times. But this 3D technology puts the information at our fingertips. And once we have this information into our fingertips, we now start to see the reality of the anatomy, reality of what we have as we are moving along in our treatment planning. So for guided surgery, this is part of the essential goals. We need to have this tool. We need this tool to be able to assess and plan. So I just want to give a quick shout out to the Digital Dentistry Society, of which Dr. Ganz is an ambassador of, and or board of directors of, excuse me. We do have a Digital Dentistry Society in the United States as well. So become a member, learn a lot more about the digital dentistry and about the society itself to make yourself a digital dentist. I believe that is the direction of where things have been going, and maybe with the exception of this year's graduating classes who might not be able to graduate, all the young bucks coming out of school are already concentrating on the digital aspect and digital side of things, and they are embracing it. So we need to embrace this technology so that we too can stay on the cutting edge and deliver the best possible care to our patients. So the old adage is to have a blueprint, right? We're not going to build a house without having some sort of a blueprint. And we always like to say, measure twice and cut once. We're going to cut a piece of wood for a section of the house. We want to measure it twice before we go and make that cut, because we're not going to get a second chance at it. So when we do our treatment planning, we want to make sure we have that cone beam, we have that planning, and that we're doing our planning a few times sometimes to just be able to assess the correct necessity for that patient, and then be able to deliver it properly. And we can do that in a freehand approach. We can do it in a template assisted approach where we use maybe some kind of a stent to help us guide us in place, or we can use it with a static guide or a virtual dynamic guide. So there's lots of different ways to use that information once you have it. The digital workflow for this blueprint of success is to have some sort of a wax up in advance, or a copy of the patient's record in advance. So we do need to take either a study cast or intraoral scan, and then we want to merge that with the cone beam together. We want to merge the two data sets together. And then we want to be able to make the plan. As you see in the bottom right corner here, we're actually making the plan in the software. And then we can figure out our surgical intervention. Should this be a bone supported guide? Should we do no guide? Should we place a template for this guide? We have lots of different ways to be able to go ahead and skin that cat, so to speak. And I know that this may all sound like Chinese, so why don't you read the Chinese version of the computer-guided applications written by Marco Rinaldi, Scott Ganz, and Angelo Matola, or you can read the English version, which is my preference, of computer-guided applications. It's a wonderful book. I highly recommend it. It's going to give you all the details you need to begin your digital journey. So first, we need
no virus associated with the Chinese version that I'm aware of.
Very well said. So we do need to have that pre-op data collection. So whether or not you already have a, if you're comfortable with just impression scanning and then maybe scanning that impression, because there are scannable impression materials, or scanning the model, that model that you poured, but getting that into a digitized format so that we can then use it in a computer fashion, or whether or not you're going to go into the world of intraoral scanning, which is my choice. I have about 6 different scanners in my office. I love them all. The Carestream, 3Shape, you name it. We have them here. We love them. And we love to use this ScanMate appliance to help us do our retraction, because it's a non-reflective device, something created by our dear friend Cherie Lipinski at Armor Dental. Cherie's just been incredible at continuing to make devices, and new devices are coming. But this accuracy from the intraoral scanning is definitely superior towards taking a standard impression. There are many articles on this. Our good friends are up here that all have written some great articles about accuracy and accuracy across different intraoral scanners. So I highly recommend you take a look at some of these articles. And once we have that data set, once we have either the model scan or the impression or the digitized intraoral scan, and we combine it with the CBCT, we then can go ahead and plan. And we can plan with a surgical guide, as I was used to many years for doing, and I still do employ surgical guides. There are some situations where I do want to have some surgical guides, but we can also plan on going virtually in some of these cases and using some dynamic guidance. So we have these 2 types of guides that we could create. We could go free-handed, or we have these 2 types of guides. We can have a static guide, which is seeing on the left side of the screen, or we can have this virtual dynamic guide, which is just like having a static guide, but without the interference of a static guide. So it's a wonderful addition to the dental industry and actually into the medical industry as a whole. So I want to thank Francisco Casadisas, who was my trainer for Navident. I was introduced to Navident. I've been introduced to Navident years ago, but I was started using Navident about a year ago. And thanks to Jason Pardo in Navident, and Doron Deckel and Ken Sirota and others who convinced me that I should be looking into this technology because it was kind of groundbreaking. And once I got more immersed into it, I realized just how valuable this tool actually is. And I'm very thankful for their training. They do a wonderful job of training us how to use this technology. And the advantages of going into a virtual dynamic navigation is quite simple. We have some wonderful articles that were written by Stefanelli, which is a Jomi article, and also by Michael Block and Emery, and also a Jomi article that have estimated the confidence and the accuracy of using these dynamic implant navigation systems. And there are a few of them out there. And then there's the question is, oh, well, which one do I go with? And that's a prerogative that you can decide on your own, and I might be able to give you my opinion, but it's a prerogative of the user itself. But in these articles, they described how dynamic navigation can achieve the accuracy the same as a static guide, and certainly much more accurate than free-handed guided placement. So if we can have something that's as good as a static guide, and I believe once you get really good at this, that you can be even superior to static guides, because it's kind of like playing a video game. The more you play it, the better you get. It's basically that simple. You just have to keep moving along and not just let it sit in the corner. Use it some more, and you will get better. You will get the dexterity, the understanding, the ability to start sitting back and looking at a screen instead of sitting down and looking at a patient, having the comfort in your back, having the tools that you need to be able to do this in a guided manner, in a controlled manner, which I think is unparalleled in the industry today. It's basically GPS for implants. So we have that ability to guide us in the proper foundation.
So you're saying that there is a learning curve in adopting this technology.
I think with any technology, there is a learning curve. And if you're going to think that you're going to pick it up and be an expert at it the day one, there is no way. And it does, some people, I'm sorry, I shouldn't say that. Some people are so good with with, let's say, video games or other types of virtual reality things, that they can just jump right in and grasp this quite quickly. I must say my journey did not take long. I've heard from other people that it took them, you know, a few weeks to get really comfortable doing it. When I got this in my hands, by my third case, I was ready to do something more drastic. And I'll show you one of those cases in just a moment, because I felt very, very comfortable. We had planned to do something else, and then we changed our treatment plan because I felt so comfortable doing it. But
what I wanted to interject was that there is without question going to be a learning curve for anyone going into this technology. But what we have seen, Isaac and myself, at our live surgical courses, where we've been integrating dynamic navigation with some of the participants doing it for the first time, it's really amazing how right on they are on their very first case. So although there is a learning curve, it's going to be based upon your own hand-eye coordination and surgical skills, and you can in fact get it even on the first try.
Oh, absolutely. So getting it is not the question. Getting it is almost a guarantee, because you have to follow along the template. The question is how comfortable. My statement was more about how comfortable you will feel. When do you feel like you'll break the shackles and kind of be diving right in? And that takes sometimes for some people a couple of weeks. For me, it was nearly instant. But as we saw just at our last surgical course just a few months ago, before all this chaos hit, we had a bunch of students doing it, and attendees, excuse me, and some of them were novices and some of them were long-time implant users. And when we did our evaluations at the end, when we compared the before and after, these guys nailed it. I mean, they were right on. And if you remember, one case was at like a 0.01 accuracy. I mean, that's something incredible. So you will get it. You will be doing it the right method, and you will have the right outcome. But the comfort level of just having it in your, learning how to hold everything, making sure that we can calibrate all these little pieces, that takes sometimes a little bit of a learning curve. But as far as success, you're going to have success with it basically from day one, because you're seeing what you're doing in real time. And part of the unique versatility, one of the reasons I went with Navident as opposed to some of the other systems that are out there, was the versatility of the unit. Being able to use a piezo unit, being able to use a high speed, a low speed, to calibrate various different devices and various different tips. And I think that's the key, because it doesn't limit me to just placing an implant or drilling an osteotomy. This opens up a whole new door. I can have a saw tip for ridge splitting or lateral sinus windows. If we want to encroach that, if we want to harvest a piece of bone, we can outline that piece of bone and harvest that with a saw template. We can use various different high speeds and low speeds, which is going to come in to become very important into some of the cases that I'm going to show you in just a moment, or one of the cases at least that I'm going to show you in just a moment. So the other addition that basically sold me, this is when I said, okay, I'll buy it, was when the trace in place came out. By being able to allocate 4 or 5 different locations and being able to trace along with a tracer, we no longer need to have any adjunctive pieces that go into the mouth like a stent or anything like that. We can now validate what we're doing just simply by taking a scan. It's nice to have an intraoral scan as well to overlay that, especially if there's a lot of metal. But if there's no metal, like in this case here, on a mannequin, we can go through and we can plan our cases without having interference. So we can do this just from the CBCT, get points of registration, and simply get to work. So it's just a matter of importing the CBCT into the software, selecting a few dots, tracing around those 2 dots, and now you have your virtual dynamic template that we can start with. We can plan the implants like you're seeing here, and then go ahead and place them. Now, I do not want to make it that I am an expert in this field. I am still just a novice. I've only been using this for a year, and the last month and a half, I haven't been able to use it at all. So I highly, highly recommend listening to some of these other webinars that Navident has in store for you. There's one that just happened last week, and then we have a bunch more coming this week. You have George Mandelarius and Sylvia De La Rosa, who is absolutely phenomenal, and Bobby Nagu and Paula Villa and Joey Chen. And Joey Chen published something beautifully, which I'll show you in just a moment. But these are the true experts. I may have come up with a couple of my techniques that I'll show you, but these are the experts in the field. I highly recommend, don't miss their webinars. It's going to very much be worth your while. You'll learn a ton from them, as I have already. So when I see a case like this, and I'm thinking already, well, I got to extract that tooth. Now, it's not possible for me to save it. It's not restorable. And you can see actually the zenith line is quite off, but I do want to try to save this. I was going to originally extract this tooth, and then I thought about perhaps doing this partial extraction therapy technique in this case. So instead of extracting the entire tooth, I'm only going to extract part of that tooth. And I want to give a quick shout out to Joey Chen, who published in the Journal of Oral Implantology, Navigation System and Socket Shield in October of 2019. It's a great article, highly recommend reading it. But in this article, he shows and discusses both the implant planning, and if you notice here, he's planning a little miniature implant so he can find the apex, which is, this article didn't come out when I was performing that other case yet. But this article actually it shows you a step-by-step as to how to do what I'm going to show you in a moment, which is to plan basically a miniature implant, find your apex, and then look and see almost like a sonogram where you're cutting along to cut out this root, and planning a implant placement and placing that implant into that exact position. So congratulations, Joey, on this article from October. So on that same case, we're going to pick 5 new locations. I like to pick 5, the more the better. Sometimes we don't have 5, but we on the maxilla, we have a head tracker instead of attaching something to the lower mandible, because the lower mandible is movable. So I was able to do 5 quite easily. And then we can validate those 5 points of tracing and ensure, and you can see I'm at 0.01 millimeters of accuracy. So, or negative 0.1 millimeters of accuracy. So we are highly accurate at this point, and we can now move on along and go ahead and try to attempt to perform this procedure, which is going to be a partial extraction therapy on this anterior central incisor. Had my numbers not been this accurate, I would go back, retrace, redo my trace in place, and then go ahead and validate my accuracy again. And between each drill that you're going to use, you want to calibrate and check the accuracy. It's important to keep that accuracy. If we lose the accuracy, then we're kind of back into freehand zone, and we want to be in a better position, which is as accurate as possible. So we used, in this case, for this partial extraction therapy, the root membrane kit available from Megagen, which was developed by my dear friend Mitziadis and others. And we use this technique, this drill kit specifically for their length of drills. We just did a case recently with navigation with Dr. Howard Gluckman's new PET kit, and it worked beautifully as well. But the key is to have nice long burrs that you can work with, so you can calibrate, and then you can be able to reach the apex of these teeth. So here we are holding up a calibrating tool with the drill, holding it steady, and the camera, this camera is sensing where we're at, and it's going to calibrate that measurement, so it's going to know where we are in real time. And you can see this burr right here, and this burr has a little stopper on it, so it has a 7 millimeter stopper. So we can use that to make our initial cutting. So we're going to section this tooth from a mesial-distal fashion. We're going to cut back. I like to go as interproximal as possible to try to support the papilla by leaving this remaining root fragment. So I try to create almost like a C shape on the anterior segment. And then we go in toward finding our apex. So we're first going to find our apex, and if you look in the right side of the screen, which is what I'm looking at. Now what's going on is on the left side, but I'm watching the right side of the screen as I'm preparing. I'm not looking at the patient's mouth, and we are following along the root trajectory, looking for that apex and starting to cut that root out horizontally. So we're able to see in real time, almost like a sonogram. And you can see this cut in here, and there's my access hole to where my apex was. We then can extract our tooth. Now I'm using a peritome here, and an elviatome from my company, TBS Dental. So I am biased. I believe this is the best instruments. There's my Scott Ganz forceps to remove the remaining root tip. And then we're prepping, again, we can do this in real time or freehanded. we're just prepping the internal aspect of that root, debriding out that site, and we're going to go and start to look into implant placement. But before we can place an implant, we have to drill the osteotomy. So again, the versatility of being able to use different handpieces, high speed, now I'm back to low speed handpiece, and I'm using these DINAMIS, OSSEODENSIFICATION, so I can get better implant stability. And I'm going to hang palatally. And if you look at this screen right over here, you'll notice that I'm aiming for this little orange dot, and this is showing me my depth and my position. I'm not looking at this side of the screen. You might be, because you might want to see what I'm doing. But the reality is this is what I'm concentrating on. I don't care what's going on here. I only care what's going on the computer screen. So it's seeing me in real time, and I'm able to position and follow my access here. And it's telling me how many degrees I'm off, how many millimeters I'm off in vertical depth and in position. So this is a key aspect, especially when we're going to talk about the sinus lifting. You can see I now have my osteotomy prepped. My shield or root membrane has been reduced. And we have created basically a curved root. And now we are going to place our implant. So we're going to calibrate that implant again as well, so that we can measure our accuracy. So we calibrate the implant and we place it in. And again, we're starting out at a depth here, and it's going to go all the way down to the base of that depth. And I'm watching my position here. Even though I've drilled my osteotomy, I still want to make sure I'm as perfect as I can be. And I'm going to straighten it out towards the very, very end. And once I hit red, I know I'm done. I'm at that spot. I do not want to exceed the red in this case. And you can look at this measurement and overlay here. We're pretty much almost dead on. So you can see our placement, and it's palatal. I can leave a little bit of an area to graft. That's your preference. And I'm going to take my ISQ. Why? Because I want an objective measurement, and I want to know when this is ready. So I place my healing cap. This is a little bit of a blue M gel, an oxidizing gel that I like for healing. And if you want to suture or not suture, that's up to you. But in this case, we didn't use any graft material other than that NovaBone material. When I'm completed, I can then take another CBCT scan, and I can export the data into the import the data into the Evalu navigation software. How do you know that a company is standing behind this product? When they give you a software to be able to evaluate the quality of what you're doing. So they want you to get better and better at this. So what we can do is superimpose these two scans. You can see the checkerboard here. This is the overlapping of the two scans here. And when we evaluated this, our final readings, which is you can't see down here, so I wrote up here, on entry, the way that we entered our osteotomy, we were off by 0.05 millimeters. Our apex was off by 0.75 millimeters. Our angle was off by 2.35 degrees. That to me is extremely accurate. You can see the red and yellow are almost directly overlapped, so that we are basically right where we planned. And notice something here. We were hanging out right by the nasopalatine canal. So this is a great tool to use around anatomically considerations of cases such as mandibular nerves and the maxillary sinus. So in the 7 cases, this is the wrong slide, I apologize. This is the osteodensification slide, but in the number of cases I will show you later on, we'll flip-flop those back in a moment, but I'll get back to you on that, I apologize. Let's talk about the digital dynamic sinus. How can we use this for the maxillary sinus? So using the same methodology, we have a case here. This is a nice case to start with. We have about 6 millimeters worth of residual height. We have plenty of width. It's an easy case for me to start trying to work on a sinus lift, because worst case scenario, if I perforated or something like that, I can just place a shorter implant and wider implant if I wanted to. So it was a good case to start out on. So here we are using the DINAMIS. We've used the pilot burn forward first, and then after that, we're drilling in reverse at 1,000 RPM or 1,200 RPM, but your choice. But we want to stay 1 millimeter short of the sinus floor. And this here, this is what I'm looking at. I'm looking at my planned implant short of the sinus, short of the membrane, and you notice that I stopped 1.1 millimeters short of the sinus. I can't guess that if I'm doing that free-handed. Even if I have markings and measurements, I still can't be as exact as that, especially when I'm making a miniature flap like you see here. And then we continue along, and as we get wider with the DINAMIS, we can start to go past the sinus floor or break the sinus floor, which is what I just did with that little red line. I just broke through. I know I broke through, so I can pull my drill out, which I just cannot know unless I have the tactile feel where I perforated through. I won't know. So here I can actually measure to the 10th of the millimeter of when I break through that sinus floor. And I can take an x-ray to confirm. And then I can start adding my bone graft material. And this is another reason why I love using the NovaBone material, because it fits so nicely inside. And now I'm going to purposely pass with the NovaBone past the sinus floor, so you'll see me go red. And I want that hydrodynamic lift to help continue to push that bone graft material further up along. I then calibrate my implant. And I'm going to place that in, and I'm going to add more bone and then place my implant. So I add a little bit more. I place my implant, and now if you notice on the screen, look how far past I'm passing. I'm going to pass way past. The implant is going way past. It's going to go a little bit further than that. Unfortunately, the video got cut off there, but it goes further than that, so that we pass more like 3 millimeters past the sinus floor. We're going to measure our torque. You can see on the x-ray we passed, and we have a nice volume of bone graft over there. We're taking our ISQ so we know when this is ready. We're placing our healing cap, and because it was a mini flap, I didn't even need to place a stitch. So no sutures on this case. Again, being able to evaluate how you're doing. You can do this with each case. We keep going through it. And we evaluate it through the EvaluNav software. And if you see, here's my planned implant, which is short of the sinus. My implant that's in yellow is past. This is my final outcome of my implant. And look, my entry was off by just 0.32 millimeters, my apex by 2.27, and my angle by 2.28 degrees. And that is pretty darn accurate. So we are in great shape to be able to do this in basically a restrictive-less environment without a surgical guide, but having the benefits of using a surgical guide. So just 6 weeks later, I'm measuring the ISQ, and I have an 80. And you saw my other readings were in 70s. We then load it at 8 weeks. We have our final crown in place. And you can see our post-op CBCT. You can notice our new sinus floor. Blow that up for you. You can notice our new sinus floor. We passed the sinus membrane. So in a 6 millimeter sinus, we have a brand new sinus floor. This is about 6 months later. We have a brand new sinus floor and have placed a 10 millimeter implant into a 6 millimeter site.
So that's a beautiful example of this technology, and showing how much you can achieve. But one of the things that I just want you to comment on, and you can do that after you show the graphic here, and that is that there's a lot of people that think that you're going to get dynamic navigation. You're going to put the patient in the chair, look at the case, and say, okay, now I'm going to put an implant in, and not understand that what you're creating is a virtual template that requires the same amount of planning as if you were going to do a static guide. Would you comment on that?
It's exactly right. It requires the same amount of planning, but without all the extensive amount of lab work that goes along with it. So we have the benefits of static controlled guided surgery, but without the labor of laboratory work, unless you want to go to making a, let's say, temporary crown in a laboratory setting, there's really no lab work that's required. If we're working on the upper jaw, we have a head tracer. Working on the lower jaw, we just bond a simple piece into the jaw to be able to track the lower mandible because it's always in flux. So we have that at our disposal. You'll see from.
But you would still want to integrate now with the latest versions of the software for Navident. If you had diagnostic wax up and bringing in STL files, and so that you could maximize your planning, correct?
Oh, absolutely. And we can actually, the updates to the software actually have crowns that are prefabricated, a library of crowns that we can open and put right directly into the software and plan based off of a prosthetically driven approach. So beforehand, where we used to have to create these wax ups so we can truly plan it prosthetically driven, as you've lectured on for a few decades already about prosthetically driven implant dentistry. This is a prosthetically driven approach. We had, on those cases, we planned a crown. We scanned the patient, we made a virtual wax up and imported it. Now we don't have to do that. Now we can actually, the crowns are there. You just select the crown, change the dimensions. We can bring it into occlusion if we want. We can figure out where we're going and deliver it in a prosthetically driven fashion. And we can even go ahead and make final or temporary abutments. My latest thing is that I have a case set up for a final abutment. And you'll see from some of the others, there's from the other speakers, there's some amazing techniques and tricks as to what you can do with navigation. So we are in the infancy in the digital age. I know people love to think that we're at the apex and all that of this. We're just barely climbing the ladder. As you've so eloquently put many times, we're on the start. We've just started to get the tools. We're bringing them in slowly, and we are starting to climb. And we have not even come close to where we are, where the evolution of digital dentistry has been in its full swing. So in this early infancy, it's great to be a part of it, because as you get into something early on, you get to be a part of the building process of it. When you enter things very late, it's very hard to necessarily jump in and catch up on all the stuff from the past. So one of the reasons that I was jumping in on this is I was made privy to some of the things that are going to be happening in the future. And I'm not able to say online here what they are. But let me just say this, that the future is extremely bright, extremely bright. And now to me is the time to get into this before there becomes so much information that you're caught behind. It is getting easier and easier to use. It's now very kind of foolproof for the most part, but it's the time to get in. If you haven't been involved in this already, it's the time to get in. For basic implants, for full arch implants, for cases like this of socket shielding, root membrane, or for sinus lifting, and for many other different types of techniques. So just to finish off the lecture is to be as precise and accurate as we possibly can. We want to do we have some full arch cases that we've done with this. We have some individual cases here, some of the sinus cases that we've done, and 2 of the full arch cases that we've done. But it's all about precision and accuracy and how precise and accurate we can be for the betterment of our patients. And that's the key. Our patients, as you always say, our patients are coming to us for teeth. How we're going to deliver them is up to us. So we have to look at the best manner to which we can deliver that. Sometimes that may be a static guide, and sometimes that may be free-handed for all that matters, because the patient needs an implant that day. And other times, and you don't necessarily have a navigation system. And other times it's going to be using virtual navigation. So I would say that, that most of my implants are being placed by navigation, and I hope in the near future I'm going to be placing all my implants under navigation, not just the 75% or so that I'm doing now, as we keep expanding upon these and even finalize more protocols for some of these full arch cases. So just to give a little shout out, we are having our first online digital symposium. This is going to air on April 30th. This is part of the Minec, the Megagen International Network of Educators and Clinicians. And we have 12 amazing speakers, well, 11 and myself, speakers that are absolutely fantastic. These are all Minec nights. We have a great digital workflow session, as you can see down here. So you have some really super speakers here. We have some amazing moderators, Dr. Park, Dr. Andre Sadoun, Dr. Jafar Muhir, and of course, the legendary Dr. Scott Ganz. So this is going to be a great symposium. Please don't miss it on April 30th. So very proud of that. It's going to be a one-of-a-kind event. It's going to start early in Tunisian time, and we'll have this recorded. It'll be available both on the Minec website, which is minec.ac, and it will also be available on the AIE website, which is aiedental.com. So please don't miss that. That's April 30th, and it'll be on Facebook Live. One little quirk that I want to mention: we're all been stuck in quarantine lately, and I just built a new house, and I have this lovely basement, and I installed a gym in my basement, and it's been great being in quarantine for one reason, not for what's going on in the world, but to be with my wonderful family. I have 4 beautiful children. My wife calls me the 5th child, and she's a wonderful woman, and I'm very lucky to have them. And during these quarantine days, we've managed somehow to destroy the gym and now make it look like this. So we went from pre-quarantine days, and this was at day 17, and it's only getting worse. So I just want to wish all of you to be safe, be careful. I know it's a dangerous world out there right now, but if we just be safe, be careful, we should be in really good shape, and hopefully this world will come out stronger and better from learning from these experiences. And when you do come back out into the world, try to think of some of the tools that you can use, such as dynamic navigation, to make you separate from some of the competition that's out there, make you a better clinician, make it better for your patients, so that you can then start to offer something. So take advantage of the time. I know there's a lot of webinars going on, a lot of things to absorb. Watch some more of these navigational webinars, learn a lot more about digital navigation, dynamic navigation, as I have, and I will continue to watch these upcoming webinars, and embrace this modern technology and all the modern technology, and figure out how it can benefit you in your practice. So I want to thank you for your time. This is our email down here is my email. If you want a PDF copy of this lecture, feel free to shoot me an email. I'm happy to send it. And you can visit our website, Scott and I's website, at aiedental.com to see what we're up to and the latest things that we're doing. So I'll turn it over back to you, Scott, if you want to make any comments before I give them the CE side.
Yeah, I think we're going to have maybe a couple of questions. I know that some of the people have written in, and first of all, you covered an amazing amount of material in a short amount of time. These are, I think, for most of that, most of the cases, maybe people are not as familiar with socket shield, and certainly using osseodensification for transcrestal sinuses. So really an amazing amount of information that was really well documented. One of the questions from one of the participants was, when you're dealing with a, and certainly everything is based on a cone beam CT evaluation, as you said. But one of the questions was, how do you deal? If you're trying to do a socket shield type case, what happens when you have a curved root?
Wow, that's actually a great question. I think that's where it becomes the most complicated cases that we have are these curved roots, because you have no idea where we are in the jaw. So if we have a severely curved root and we're trying to access the apex of that root, how are we going to find the apex of that root? So typically in the past, when I was trying to find these curved roots, I would make a guide, a 2mm pilot guide that would take me to that apex. But now with dynamic navigation, I can plan basically a miniature implant into that section where the curved root was, and know that I've actually hit that apex to the 1/10 of a millimeter. So having that curved root is no longer an obstacle for me. As a matter of fact, it may be a tremendous benefit. If it's let's say a lateral incisor that's curving towards the canine, I now will be able to cut out that root towards the curve, where that apex is of the curve. And now I have a nice amount of non-disrupted bone where I can place my implant in a perfectly straightened out parallel position. So that curve, when I see those curved roots, I immediately think maybe immediately loading, because of the fact that I'm going to have a lot of undisturbed bone that hasn't been drilled for an osteotomy. So removing the contents is quite easy with dynamic navigation or guided navigation. Without it, it is a little bit tricky. And if that curved root becomes very close to the adjacent PDL of, let's say, a canine on the lateral incisor, or a nasopalatine canal, or a mental foramen, or something like that, it could start to get a little bit dangerous. So it definitely is in our advantage to have some of these tools at our disposal, such as static and dynamic virtual guides, to get us to those curved roots. But they are doable, they are possible. It's not a case I would start with, but certainly ones that we do quite often in the practice here we've been doing socket shield for 8 years, partial extraction there for 8 years, and it's become commonplace for us. Those are actually now my favorite cases, because I'm usually thinking immediate load same day.
And you very nicely showed that this is not just a procedure for anterior maxillary incisor cases. It's one that can be used to preserve. It's not just about preserving the buccal, bundle bone, that area where we normally see resorption, but as you showed in the molar area, it's also about the volumetric changes that can occur when you have an extraction and you don't graft, or you have an extraction and then you place an implant without grafting. This is a really viable alternative that requires, though, a real good understanding diagnostically with cone beam CT. Now, we had another question that someone, I think you went over this kind of quickly, so they may not have quite understood, but you mentioned in terms of osteodensification and if you have, what kind of bone that you would utilize for, let's say, a transcrestal approach, or if you had, let's say, also a case where you grafted using a xenograft, is that a solution for using the densiburs and trying to osteodensify?
Right. So two good questions. So you can use whatever you want in the sinus. There's definitely no issue, right? The sinus loves to grow bone. So it's as long as we can scaffold that bone material, then we can grow bone, whether it's a xenograft or an allograft or a alloplast for that matter. I'm not a huge fan of alloplast, but you can certainly use whatever you like. Mineralized bone, demineralized bone, xenograft, no problem, entering and pushing into the sinus cavity. However, if I am going to not graft a site and I'm going to come back later to go ahead and place an implant, if I have a big ridge that I've grafted with a xenograft and I try to come back in and now I'm going to drill in reverse and compact that bone with osteodensification, then what's going to end up happening is I'm going to compress all the vital bone that I've been developing, and I'm going to leave remnants of the xenograft bone. So there's not going to be enough vital bone left for us to be able to place an implant properly. If you do place the implant properly, it's kind of like rolling the dice, because we have to hope that that area is somehow going to get revascularized. Because as we know, xenograft doesn't turn over. It's just scaffolding and holding bone, and then bone forms in between. So with the osteodensification, we may have squeezed all that natural bone and blood vessels that were supplying and housing that, forming lacuna around those xenograft particles, and we eliminate that, and then inside can end up like looking like Chernobyl inside. It can all turn to mush, and it won't develop properly, and we may have a massive failure, which we found early on. We learned early on with osteodensification not to graft sites, not to use xenograft as a graft material and then come back and graft it. If you want to use xenograft as an additive, I'm not saying not to. Certainly, you want to veneer the buccal after let's say you've osteodensified a site and veneer the buccal for an augmentation, or you want to add it into the sinus, there's no issue with that whatsoever.
Well, I think, the other issue that I just want to make sure that we impart to the audience is that we don't want people running out there and trying to push the envelope, especially with these transcrestal cases using densiburs. So we don't want them trying to, on their first case, trying to raise it, 6-8 millimeters. That's just not the way it was designed. So you've been able to push the envelope based on your experience, long experience in utilizing the technologies. But I just want to, caution everyone that we want to be able to go slowly and understand the limitations. And as you get better, and it's the same thing with dynamic navigation as you go through that learning curve.
Agreed. Very good. Very much agreed.
Okay, well, if anybody else has a question, this is the last time to be able to throw it in on our chat. Otherwise, we're going to turn it back over.
Okay.
To Beth.
Yes, hi, thank you. That was really one of the best presentations I've seen in a long time. Really appreciate the effort that was put into it and the clinical expertise, as well as the give and take between the two of you. It was really, really quite special. So thank you very much. And for the attendees, you will be receiving an email shortly, probably by Monday, since today's Friday, with a link to the email. It will be sent to the email that you're registered with. And it will be a link to not only the CE documents, but also the recording of this webinar and registration links to our upcoming webinars. You can also copy and paste the link that we have right here on the screen. So again, thank you so much to our panelists and our attendees. I hope everybody stays well and stays safe. and hope to see you soon at another webinar. Good night.
Thank you, Beth.
Thank you.